Hi everyone, my name is Nurshara Bitaliban and today I'm going to talk about atrial fibrillation versus atrial flutter. But before that, we must actually know what does it mean by cardiac conduction system. So basically, cardiac conduction system is a network of nodes or specialized cells, specialized conduction cells that work together that initiate and coordinate the contraction of the heart muscle. Alright, so the conducting system of the heart consists of 5 main components, which are: the first one is sinoatrial SA node, atrioventricular AV node, bundle of hairs, right and left bundle branches, and last but not least is the Purkinje fiber. Sinoatrial SA node, also known as node of Keith's flag, is a small horseshoe-shaped mass having specialized myocardial fibers located in the wall of right atrium, just below the opening of the superior vena cava. The SA node, also known as a pacemaker of the heart, as it generates impulses about 70 per minute and initiates the contraction of cardiac muscle, producing heartbeats. Atrioventricular AV node, also known as node of Tawara, is smaller than SA node and it is located in the lower part of the atrial septal, just above the attachment of the septal cusp of tricuspid valve or the opening of the coronary sinus. So it conducts the cardiac impulse to the ventricles by bundle of hairs. So the AV node is capable of generating impulses at the rate of about 60 per minute. The speed of conduction of cardiac impulse of about 0.12 seconds provides sufficient time for the atrium to empty their blood to the ventricles before ventricle starts to contract. Atrioventricular bundle, also known as bundle of hairs. So it begins from the AV node, crosses the AV ring, and runs along the inferior part of the membranous part of the interventricular septum, where it divides into the left and right bundle branches. Since the skeleton, which is a fibrous framework of the heart, separates the muscle of atria from the muscle of ventricle, the bundle of hairs is the only means of conducting impulses from the atria to the ventricle. Next is the right and left bundle branches. So the right bundle branch passes down to the right side of the interventricular septum and becomes subdo-endocardial on the right side of the septum. So a large part of it continues into the septomarginal trabeculum to reach the anterior papillary muscle and anterior wall of the ventricle. So its Purkinje fibers then spread out beneath the endocardium. The left bundle branch, on the other hand, descends on the left side of the intraventricular septum, divides into Purkinje fibers, which are distributed to the septum and left ventricle. Lastly is the Purkinje fiber. So they are the terminal branches of right and left branches of the bundle of hairs and separate subendocardially over the septum and the rest of the ventricular wall. Okay, so the heart is a muscle that works continuously, much like a pump. So each beat of the heart is set in motion by an electrical signal from within the heart muscle. The electrical activity is recorded by an electrocardiogram, also known as ECG or EKG. So each beat of the heart begins with an electrical signal from the sinoatrial node, also known as SA node. So when the heart's right atrium is full with blood, the electrical signal will spread across the cells of the heart's right and left atria. So this signal causes the atria to contract. So this pumps blood through the open valve from the atria into both ventricles. The P wave of ECG marks the contraction of the heart's atria. So these signals arise at the AV node near the ventricles. So here it is slowed down for an instant to allow the heart's right and left ventricle to fill with blood. On ECG, the interval is presented by the PR interval, that is from the beginning of the P wave until the Q wave. So the signal is then released and moves next to the bundle of hairs located in the heart ventricle. Alright, so from the bundle of hairs, the signal fibers divide into the left and right bundle branches. On ECG, this is represented by the Q wave. The signal then leaves the left and right bundle branches through the Purkinje fibers that connect directly to the cells in the walls of the heart's ventricle. The signal spreads quickly across the heart ventricle. So as the signal spreads across the cell of the ventricle wall, both ventricles contract, but they are not contracting at the exact same moment. So the left ventricle contracts an instant before the right ventricle. On ECG, the R wave marks the contraction of the heart's left ventricle, while the S wave marks the contraction of the right ventricle. the contraction of the heart's right ventricle pushes blood through the pulmonary valve to the lungs, while the contraction of the heart's left ventricle pushes blood through the aortic valve to the rest of the body. So as the signal passes, the walls of the heart's ventricle relax and await for the next signal. On the ECG, the T wave marks the point of which the heart's ventricles are relaxing. This process will continue over and over again. It's like a cycle. Alright, so now since most of us know how the normal conduction system works already, right? So let us take a look at the diseases or at the abnormalities of it, which are atrial fibrillation and atrial flutter. Atrial flutter and atrial fibrillation are both abnormal heart rhythm. They occur when there is an issue with the electrical signals and pathways in the heart, which usually leads it to beat in an organized, effective way. So normally, the atria contract and push blood into the ventricles. However, in atrial fibrillation, the atria beat irregularly, while in atrial flutter, the atria beat regularly but faster than usual and more often than the ventricles. So patients may have 4 atrial beats to 1 every 1 ventricular beat. So atrial flutter is less common, but both of them have similar symptoms such as feeling pain in the jaw or neck, dizziness, palpitations, and shortness of breath. Some people have mild symptoms while others have none at all. So about 1/3 of people with atrial flutter may also have atrial fibrillation. Both conditions carry an increased risk of stroke, usually managed by drugs such as warfarin or a newer anticoagulant. So this is why whether a patient has an atrial fibrillation or atrial flutter, it is very vital to be diagnosed early so the right treatment can be done as well as reducing the risk of stroke. Alright, let us differentiate between the atrial flutter and atrial fibrillation based on the ECG criteria. So firstly, let us take a look at the atrial flutter. So atrial flutter is a condition in which the atria of the heart are affected by electrical or conduction problems, resulting in a re-entry loop which causes the atria to beat rapidly between 240 to 360 beats per minute. In electrocardiogram or ECG, atrial flutter waves appear as regular sawtooth patterns or small P waves followed by short or no intervals between them. In some cases, flutter waves do not completely reach the ventricular heart chambers due to electrical conduction blocks. This results in a 2:1, 3:1, or 4:1 ventricular contraction rate that is mostly regular. So most cases of atrial flutter occur when the atria beats at 300 beats per minute and the ventricles contract at 150 beats per minute, where some patients with flutter waves may also have bradycardia because most of the flutter P waves are not reaching the ventricles. On the other hand, among tachyarrhythmia, atrial fibrillation is the most common cases. There are about 27 to 28 cases per 1,000 person each year. So in atrial fibrillation or AFib, the atria of the heart have electrical problems that result in a chaotic electrical impulse. The production of your complex is irregular with no P waves present at all. So this results in the heart having ventricular contractions that are irregular, variable, ineffective blood pumping, and usually range from about 100 to 175 beats per minute. Let us summarize that what we had learned so far. So in atrial fibrillation, the RR interval are irregular, whereas in atrial flutter, the RR interval is irregular, which means that the heart rhythm in atrial fibrillation is irregular, while in atrial flutter, the heart rhythm is regular. In atrial flutter also, the re-entry loop circuit causes these changes on the ECG, while in atrial fibrillation, there are many more atrial foci that are beating simultaneously that cause these changes. In AFib, the P wave is also absent, so there's no P wave at all, while in atrial flutter, the P wave is represented in a sawtooth pattern, or we call as a flutter waves. Alright, so now that we know the ECG criteria for both atrial fibrillation and atrial flutter, so let us try to interpret the 12-lead ECG, shall we? Alright, let us start off with atrial fibrillation. So in whatever ECG that we get, we must check first the standard 1 millivolt calibration box, the AVR negative deflection, and also the correct purpose state. So in this ECG, it shows that there is a 1 millivolt calibration box, and also since there is no paper speed showing there, so we just assume that it is a correct paper speed already, which is equivalent to 25 millimeter per second. And since the AVR is negatively deflected, meaning that the placement or leads are all correct. So let us start off with the 10 steps of interpretation of ECG. So the first one, since atrial fibrillation shows that there is no P wave, so meaning that it is not sinus rhythm, as the P wave is not followed by KRS complex and T wave. second one, one of the criteria of atrial fibrillation is the rhythm is irregular. So in this ECG also it shows that this ECG has irregular rhythm, as the distance between RR interval is not constant, and the rate that I calculated is 110 beats per minute, which is we count within the 6 seconds. This is equivalent to 30 big pulses. Then we multiply it by 10. So the fourth step is exit. So in this ECG, it shows that it has a normal exit, as both lead 1 and lead AVF are positively deflected. The next one is P wave, which is the P wave is absent in this ECG since it is atrial fibrillation. And then the next one is PR interval. So we cannot also measure the PR interval due to the absence of the P wave. Next one is the QRS complex, where we can see that the QRS complex shows a normal morphology, and also the ST segment here it is also normal because there is no evidence of ST depression and ST elevation. And the ninth step is checking for the T wave in all leads. So in all leads, the T wave also shows a normal T wave with a QT interval of 0.33 seconds. Right, the next one is atrial flutter. So just like atrial fibrillation, so before we start interpreting it, we must check for the standard 1 mV calibration box, the current fiber speed of 25 mm per second, and also the AVR negative deflection to make sure all the placement of leads are correct. So now only we can start to interpret it. So the first one is to check whether it is sinus rhythm or not. So in this ECG, it shows that the P wave is not followed by QRS complex and T wave, so meaning that it is not sinus. The second step is to check whether the rhythm is regular or not. So for just like mentioned before in the ECG criteria of atrial flutter, the RR interval is regular, so meaning that the rhythm here is also regular, as you guys can see from the distance with the RR interval. And then the next one, the rate calculated is 60 beats per minute, where it is calculated by counting the number of big boxes between QRS complex to PRS complex and then divided by 300. So the fourth step is checking the axis, where it shows that in this ECG it has a left axis deviation because lead 1 is positive deflected while lead AVF is negatively deflected. So the next, the fifth step is check for the P wave morphology in lead 2. So in lead 2, the P wave is represented in sawtooth pattern and also flutter waves, and not just in lead 2 but also in long lead 2, not just in long lead 2 but actually in inferior lead, that is lead 2, 3 and AVI. It also shows that P wave has a sawtooth pattern or flutter wave. So the next one is check for the PR interval from the long lead 2. We calculate that we get 0.20 seconds. And then the QRS morphology in all leads, it shows that the QRS complex is normal with ST segment shows a normal segment with no evidence of ST depression and ST elevation. And then the ninth step is to check for the T wave morphology in all leads, that is it is hardly seen due to the flutter waves that superimpose over the T wave. So hence the QT interval, which is the last step, it is hard to measure because the T wave is hardly seen. Alright guys, I think that is all from me. So now I hope that you guys can differentiate between atrial fibrillation and atrial flutter. Thank you so much for watching and listening.